Very good morning to all of you. Today we are going to be talking about removable partial denture. This lecture is going to give you an introduction to removable partial dentures and is going to teach you how to classify removable partial denture and what are the rules that we follow while classifying partially edentulous arches. The aim of this lecture, I told you, to identify and name the different treatment modalities which are done for edentulous patients, to recognize different clinical scenarios of partially edentulous arches, and to be able to identify them using a popular classification system. When we look at the field of prosthodontics, we basically divided into three branches: removable prosthodontics, fixed prosthodontics, including implant prosthodontics, and maxillofacial prosthodontics. This lecture is going to be concerned about removable prosthodontics, in that removable prosthodontics for partially edentulous arches. That is, when a patient has one or more teeth missing, but not all the teeth missing, a removable prosthesis which is given to replace those missing teeth. That is called the removable partial denture. And that is what we are going to be seeing today. Now, why do we need to replace missing teeth? When just one tooth, that too a molar, is missing, a posterior tooth is missing, it does not affect the aesthetics. It does not affect the patient psychologically. Is there any need for us to replace the missing tooth? There is a need to replace the missing tooth and replace it as soon as possible. Because take a look at the picture. What happens here? A single molar is missing. What has happened is the upper tooth, the opposing arch, the upper tooth has migrated into the space. It has supra-erupted into the space. The two adjacent teeth on the same arch have tilted into this edentulous area. Spaces open up between the teeth on that side. There is food impaction, caries develops, and pretty soon the entire dentition on that side is going to get deranged. And as you know, when anterior teeth are missing, you have to replace them for aesthetic reason and to restore the psychological health of the patient. A removable partial denture is a prosthesis that replaces some teeth in a partially dentate arch. It can be removed from the mouth and replaced at will, also called partial removable dental prosthesis. That is, it is a removable prosthesis. It replaces some or a few teeth in an arch. It can be removed and placed back in the mouth by the patient himself or herself. There are different types of removable partial prosthesis or removable partial dentures that can be given for the patient. Okay, the first one that you see in the picture is an acrylic RPD. We're going to be using this terminology. RPD is removable partial denture. The first picture that you see is an acrylic RPD. It just consists of a base of acrylic to which the artificial teeth are attached. This is typically classified as an interim prosthesis, which is given for a short period of time. But unfortunately, in our country, due to the socio-economic reasons, this has to be used by many patients on a long-term basis. Okay. Typically, when we say removable partial denture, what we refer to is what you're seeing in the second picture. The combination of metal and acrylic to which teeth are attached is called the cast partial denture. When we refer to removable partial dentures, theoretically, we are talking about these cast partial dentures. The cast partial dentures are a combination of metal and acrylic to which the artificial teeth have been attached. There is another type of removable partial denture. Look at the third picture. Crowns have been placed on all the remaining teeth, and there is an attachment placed at the end to which the removable prosthesis can be clipped on. It is some sort of a semi-fixed prosthesis. Okay, it can be removed by the patient, clipped on back by the patient, but there is more retention because these attachments are involved. It has definitely more retention than a normal cast partial denture. This is what a typical cast partial denture looks like. Removable partial denture or the cast partial denture, this is what it looks like. There we fabricate an metal framework. We make the wax pattern, cast it in the laboratory, and we fabricate a metal framework to which artificial teeth are attached with acrylic. Okay, so this process is called a cast partial denture. It can be given for different clinical scenarios. Now here in this picture, when you see a few of the anterior teeth and a few posterior teeth are missing. Now, how do we say that these teeth are missing? How do we communicate? I need to fabricate an RPD. How do we do that? Before we go into that, let us take a quick look at the advantages of a removable partial denture. One of the main advantages of this removable partial denture is easy to fabricate, easy to repair and adjust. It restores the function when it is required. It maintains the occlusal plane. When multiple teeth are missing, when you cannot go for a fixed partial denture, when the patient cannot afford implants, this is one of the easiest treatment modalities. There is no aggressive tooth preparation or reduction of the tooth involved like you do for fixed partial dentures. So it is much more conservative of tooth structure. So for medically compromised patients who cannot undergo implant prosthesis, an RPD is a good option. When do we give it? Now, when multiple teeth are missing, there's a long edentulous span. Fixed partial denture cannot be given. When there is a long edentulous span, the only options of treatments that we have are either implants or we go for the removable partial denture. In distal extension situation, that is when the posterior teeth are missing, there is no posterior abutment, it immediately rules out a fixed partial denture. Again, we are looking at implants or removable partial denture only. Then age factor. What do we mean by this? Now, in very young patients, you know that the pulp chamber is very large. So when you're going to prepare the tooth for a fixed partial denture, danger of exposing the pulp is always there. In such patients, it's better to go for a removable partial denture as a stopgap arrangement or a temporary arrangement and later go in for either an implant or a fixed partial denture. Then in very old patients where they cannot withstand extensive preparations, extensive chairside procedures, they cannot undergo surgeries for implants, then again you think of removable partial dentures. These are conservative treatment procedures. Not much of tooth preparation is required. So when you want it done fast, you want it done easily without destroying too much of the tooth structure, you think of a removable partial denture. Now, when the abutment is too weak to support a fixed partial denture, again, you have no other option but to go for a removable partial denture. And one of the main reasons now why we go for a removable partial denture is because the patient cannot afford implants because of the socio-economic status of the patient. When should you not do a removable partial denture? The patient does not maintain oral hygiene, proper oral hygiene, brushing, multiple caries are there, patient is not able to maintain the periodontal health, patient does not maintain proper oral hygiene, do not go for a removable partial denture. Patient has poor neuromuscular control. For example, patients with Parkinsonism, etc., where the neuromuscular control is not good. You need a lot of manual dexterity to place the RPD in the mouth and remove it from the mouth. So even in physically and mentally retarded patients, for these two above reasons, you cannot go for a removable partial denture. I told you about different clinical scenarios where teeth are missing. A patient might come into you with just one or two teeth missing, two anteriors missing, or one anterior, one posterior missing, or four teeth missing on one side and one tooth on the other side. How do you decide what sort of a situation is it? You need to have some sort of classification system. Now, when I am going to communicate to another dentist or to a lab technician or to my students or for teaching purposes, for record keeping purposes, I need to be able to identify that clinical situation. I cannot just, every single time, I cannot just write a patient with missing. For example, 11122425 has come to the clinic. That is not a very practical situation. And to formulate a good treatment plan, I need to classify that edentulous arches for good communication, for record keeping. Now, when I tell you this is a patient with this classification, the listener must immediately get a mental picture of what is there in the patient's mouth. So for all that, we need a classification. And what is the kind of classification that we need? Something that is very simple, easy to remember, universally accepted, widely used, and it should give an idea of what type of design, prosthesis design that we are going to use. One such classification system, what we are going to learn today, is the one proposed by Dr. Edward Kennedy of New York in 1923. This is the most popular, most widely used classification system for partially edentulous arches. It is called Kennedy's classification. There are 4 classes in it. There are 4 classes in it, class 1, 2, 3, and 4. Later on, in 1960, a person called Applegate added 2 more modifications to it, class 5 and 6. So that is what we are going to look at now. Now, the first class is Kennedy's class 1 partially edentulous arch. Kennedy's class 1 partially edentulous arch, it is bilateral edentulous areas located posterior to the remaining natural teeth. That is, the edentulous area is bilateral. It's on either side of the arch, both on the left and right side. It is posterior edentulous area. There are no more posterior teeth present. Whatever remaining teeth are there are anterior to this edentulous area. So Kennedy's class 1 is bilateral on both sides of the arch, edentulous area which are posterior to the remaining natural teeth. Class 2 is quite similar, but it is just unilateral. Unilateral edentulous area located posterior to the remaining natural teeth. All the missing teeth are on one side of the arch and they are posterior to the remaining natural teeth. The next is Kennedy's class 3. Look at the picture, you will get an idea of the situation. It is a unilateral edentulous area with natural teeth present both anterior and posterior to it. For example, a patient with a single lateral incisor missing, when only one lateral incisor is missing. Or in this picture, if you see, the premolars are missing. So these kind of conditions, when teeth are present both anterior and posterior to the edentulous area, come under Kennedy's class 3 edentulous arch. Now, the next is Kennedy's class 4 edentulous area. This is a single bilateral edentulous area located anterior to the remaining natural teeth which crosses the midline. Let's take a deeper look at it. It is a single edentulous area. It is bilateral, that is, it crosses the midline. It is there on the right side and the left side of the arch. And it is anterior to all the remaining teeth. There are no more anterior teeth. All the teeth present are posterior. For example, when 2 central incisors are missing. In this case, if you see, all the 4 incisors and 1 canine is missing. So this is an Kennedy's class 4. You just have to be very careful. If a patient comes with just 1 central incisor missing, or 1 and 2 are missing, it becomes Kennedy's class 4. When 1 central incisor is missing, when just 1 is missing, it will come under, please remember, when just 1 is missing, it will come under Kennedy's class 3 because it is a single edentulous area. It is anterior to the remaining natural teeth, but it is not bilateral. It does not cross the midline. When only a single central incisor is missing, then it will come under Kennedy's class 3. Only when it crosses the edentulous area, crosses the midline, it comes under Kennedy's class 4. Like I told you before, Applegate added a couple of more classes to this. This is called the Kennedy's-Applegate's modification, which was proposed in 1960. If you take a look at the picture, you will find that looks almost similar to Kennedy's class 3. It's a unilateral single edentulous area with teeth present both anterior and posterior to it. But here the only difference is the anterior abutment is periodontally, or because of caries, it is very weak. It is not capable of providing any support to the prosthesis. So that would come under Kennedy's class 5. Okay. Applegate's Kennedy's class 6 again looks similar to class 3, single unilateral edentulous area with teeth present both anterior and posterior to it. But here, the edentulous space is very small. The adjacent teeth are pretty strong. They are capable of providing complete support to the prosthesis. Ideally, these are cases which should be restored either with fixed partial dentures or with implants. But due to certain reasons, like I told you, age, socioeconomic status, etc., we are going for a removable partial denture. So these kind of cases would come under Kennedy's-Applegate's class 6. Now, are these the only situations that you see in the clinical scenario? Will a patient come with just the posterior teeth missing on one side or both sides? What if all the posterior teeth are missing and one tooth is missing in the anterior also? Under what classification would you put these kind of arches? So many questions arise. This classification in itself is not fully complete. So to help you classify this, Applegate's gave a set of 8 rules, which are called Applegate's rules, and they are meant to be learned in the same order only. Okay, the first rule says that classification should follow rather than precede extractions that might alter the original classification. That is, if the patient needs any extraction, you have to do all the extractions and only then you begin classifying the arch. Because later on, if you do an extraction, the entire classification might change. Then, if the third molar is missing, the patient has got teeth only till the second molar. The third molars, both the third molars are missing and they're not going to be replaced. We do not consider them in the classification. That is Applegate's rule 2. Applegate's rule 3 states that if the third molar is present, it is going to be used as an abutment. It is going to be used as a supporting tool. It has to be considered in the classification. Now, the same thing, the fourth rule, Applegate's fourth rule says that if the second molar is missing and it's not going to be replaced, it is not considered in the classification. The patient has got teeth only up to the first molar, and then a couple of anterior teeth are missing. Then you will look at the anterior teeth and then you will classify the arch. You are not going to consider the missing second molar and third molars. Rule number 5 is a very important one. The most posterior edentulous area always determines the classification. Now just consider a case where a single molar is missing and the 2 anterior central incisors are missing. Okay, just 1 molar on one side is missing and 2 central incisors are missing. Now, if you look at just the 2 central incisors, you will say it's an edentulous area which crosses the midline. It is anterior. So you will think of giving it as Kennedy's class 4, but that is not how it should be done. The most posterior area should determine the classification. When you look at the posterior area, 1 molar is missing, teeth are present anteriorly and posterior to it. So it would be Kennedy's class 3. Then, what about the anterior missing teeth? That's the next question that pops in your mind. Look at rule 6 for that. Edentulous areas other than those determining the classification are referred to as modification spaces and are determined by their number. Before I explain, let's look at rule 7 also. The extent of modification is not considered, but only the number of additional edentulous areas are considered. Now, for example, if you look at the first picture here, you see rule number 5 says that the most posterior edentulous area determines the classification. Now, when you look at this, the posterior edentulous area, all the molars are missing bilaterally. So it is Kennedy's class 1. Then rule number 6 says edentulous areas other than those determining the classification are called modification spaces. So you see there is one other edentulous area anteriorly. So that is a modification space. How many extra edentulous areas are there? One edentulous area. Look at the first diagram. And rule number 7 says the number of missing teeth is not important. In the anterior modification space, if you see, 2 teeth are missing, but we don't consider how many teeth are missing. It is just one continuous area. So this one will be classified as Kennedy's class 1 modification 1. Okay, so the most posterior area determines the classification. Here it's Kennedy's class 1. Additional edentulous areas are called modification spaces. The number of missing teeth is not important, only how many missing areas are there, extra edentulous areas are there. So this is Kennedy's class 1 modification 1. Similarly, you see the next figure, you will see that the most posterior edentulous area is a class 3 situation. And apart from that, there are 2 other edentulous areas. We're not bothered about how many teeth in total are missing. We only know that there is one class 3, and apart from that, 2 other edentulous areas are there. So this will be called as Kennedy's class 3 modification 2. Now, the 8th rule says that class 4 has got no modifications. It's a very simple reason. Class 4, Kennedy's class 4 states that it is the most anterior edentulous area. If at all there is a modification space, the modification space is going to be in the posterior region. Applegate's rule number 5 says that most posterior edentulous area will determine the classification. So a class 4 with a modification will not be a class 4 at all. The modification space in the posterior region, that is what is going to determine the classification, and the entire classification changes. So Applegate's rules number 8 states that Kennedy's class 4 cannot have any modifications. So these are the basic classes that we can see. The first one is Kennedy's class 1, bilaterally edentulous area located posterior to the remaining natural teeth. If you look at the first row itself, you will see 2 clinical scenarios where in the second picture, you see Kennedy's class 1 modification 1. Third picture shows you Kennedy's class 1 modification 2. Similarly, you see that modification situations can exist for all the classes, but there can be no modifications in Kennedy's class 4. Please keep that in mind. There are many other systems of classification. For example, Osborne and Lamy, they classified as class 1 is mucosa bone, they are the long span. Class 2 is tooth bone, and class 3 is combination of mucosa and tooth bone situations. Okay, these are all slightly complicated situations. They do not give us an idea of treatment planning, difficult to remember, difficult to understand also. Like this, many other classifications are there in your textbook. For knowledge's sake, you can learn a couple of them, but the most widely used and often asked one is going to be only Kennedy's classification, Kennedy's Applegate's modification, and the Applegate's rules. So before we end, let's just quickly take a look at a few clinical scenarios that can come. Like I told you, while fabricating, we have different clinical scenarios for which we have different designs of removable partial dentures. For making the wax pattern also, we have different specific subscribed designs. So how do we determine that? For that, we need to know the different components. These are going to be the different components of your removable partial denture, which we will be learning in subsequent lectures. So the main components are the major connectors, minor connectors, direct retainer, indirect retainer, rest seat, and replacement teeth and denture bases. Okay, so these are the basic components of a cast partial or a removable partial denture. Major connector, minor connector, rest and rest seat, direct retainer, indirect retainer, denture base, and artificial teeth. Okay, so let's take a quick recap. Let's look at some clinical scenarios and see if we are able to identify that. This is very simple. This is a Kennedy's class 1 situation. Now, this unilateral edentulous area posterior to the remaining natural teeth, Kennedy's class 2 situation. This unilateral single edentulous area with teeth present both anterior and posterior to it, Kennedy's class 3 situation. Here, single bilateral edentulous area anterior to the remaining natural teeth, it crosses the midline. So it is Kennedy's class 4 situation. Now, when you look at this situation, here the posterior teeth are missing. It's bilateral, so it is Kennedy's class 1. There are 2 other modification spaces, so automatically it becomes Kennedy's class 1 modification 2. Here you see the posterior area is Kennedy's class 3 and anteriorly there is one edentulous space. So it is Kennedy's class 3 modification 1. Now this is bilaterally 2 edentulous areas are there. Both are like a class 3 situation. So we'll call this Kennedy's class 3 modification 1. This straightforward case, Kennedy's class 2. This is a difficult one. Here, if you see on one side, almost all the teeth are missing. It's unilateral. Posterior teeth are missing. So it is a class 2 situation. But apart from that, there are 2 extra edentulous spaces. So this would come under Kennedy's class 2 modification 2 situation. Okay. So with that, I hope you've got a clear idea of how to classify edentulous arches, and you can proceed with the further components of a removable partial denture. And you can get a clear idea of how to design a partial denture. Thank you.